So the Center for Family Medicine was established about 45 years ago, very shortly after the specialty of family medicine was recognized. We were developed here as a joint venture by what is now the Sanford Health System and the Avera Health System. Both organizations are on our board. They cooperate both financially and logistically in ensuring that we have what we need to train physicians for our region. We also have an affiliation with the Department of Family Medicine at the Sanford School of Medicine. When a new doctor graduates from medical school, they apply to a variety of residency programs to pursue their specialty training. And that is how we get people into our program. We are very active in recruiting, especially people from the Sanford School of Medicine and from our surrounding region, because we want people who understand our communities, who are likely to stay in our areas. We're not as interested in training people who are going to go to New York or California. We'd like to train people who are going to practice in our region. And so they apply through a centralized application system called the Match. In that it's like a computer dating system. They apply to a bunch of programs, we interview a bunch of applicants, and then we come up with our list of our favorites respectively. And then the computer finds the best match for us, and so that the residents will get their preference and we get our preference, and where the two meet is who we get. We've been very fortunate. Our class of residents historically have really been a nice mix. We have a mix of men and women. We have a mix of local physicians as well as people from farther away. We have a mix of traditional students who went from high school to college to medical school to residency, and other people who've had an alternate career before they came back to medicine. So we end up with this wide range of different perspectives, different experiences, different worldviews, and they come together and create a very dynamic intellectual environment, and it's a lot of fun. As a faculty member, every day is exciting because we continue to learn as we're teaching as well, and it's a fun place to be a part of.
So I grew up in a town in northern Washington State, Point Roberts, Washington, and it has a population of about 1,500 people, and it's right on the border of Canada, so there's a lot of issues with access to healthcare. And so growing up there, I had a lot of mentors, one of them being the nurse practitioner who ran the clinic in the town. And she was really inspiring for me to practice rural family medicine. She did house calls, and she was a big part of the community. She was on a lot of committees, and she took the care of the community kind of under her wing. So that's the reason why I wanted to go into rural family medicine. And then why South Dakota? The program here seems like it's very well catered to people who want to go into rural family medicine. You get a lot of experience with OB and procedures and a wide, full scope, including people with many different health conditions and issues and things like that. And I wanted to come here because I never really spent much time in South Dakota, so I wanted to get to know if it would be a good fit for me.
So I grew up in a small town, southwest Minnesota, and community was always a big thing to me. Both my parents were heavily involved in the community. My dad's a local business owner, and my mom was one of the teachers. And I saw how the family practice doctors in the surrounding towns were just a huge asset to the community, and I really wanted to be a part of that and kind of help out in that way.
So I'm originally from the area, so I had some interest in coming back to the area, but what really drew me here was the quality of the program, the quality of the residents, kind of the culture. When I interviewed here, it gave a very family atmosphere, a positive learning experience. And obviously Avera and Sanford are both outstanding facilities to work and train at, and the ability to work at both of them provided a unique perspective to get a little different experiences in multiple systems.
So we have a new rural residency program that has started under the sponsorship of the Center for Family Medicine. We have data that shows that the majority of family physicians practice within 100 miles of where they train. Previously, there was a residency in Rapid City and in Sioux Falls. If you draw a 100-mile radius around those two cities, there's a large swath of the state that doesn't fall under that shadow. In an effort to try and improve our workforce of primary care physicians in South Dakota, we've started a new residency program that will be based in Pierre. So the resident physicians will spend their first year training in Sioux Falls, and then their second and third year training in Pierre, getting used to what a rural practice is like, and hopefully staying within that 100-mile radius. So some years back, the governor established a task force to look at the health needs of the state. The governor's primary care task force looked at a variety of different options of providing adequate manpower to meet the needs of our rural communities. One of the things that they identified as a need was for there to be more physicians trained in primary care, specifically in family medicine, who can meet the needs in our rural communities. The state approached us and asked if we would develop a rural residency program for the rural portions of the state, and that was how the Pierre Rural Residency came into being. It is funded by the state, the health department. Our goal is to train family physicians in the broad spectrum of the practice of medicine so that they'll be well equipped for practice in our region, which is mostly rural. So they need to know a little bit of everything. Know how to treat most things, and when to recognize something that needs to go to a higher level of care, which often means transportation to a larger city.
So as part of my medical school training, I spent some time in Laverne, and 5 of the doctors who worked there trained at this program, and I saw that they did all aspects of family medicine quite well. Hospital, obstetric, emergency room, clinic, and nursing home care, and I saw that they had trained really well, and I wanted to take part in that training as well.
So it's really the hub for them to receive their medical care. It's someone who can know the patient, know their family, know where, the background that they've come from and the issues that they've had in the past. It's someone who can help refer them to specialists if they need extra care.
It's important for a healthcare system to have a solid basis of primary care physicians. There's a lot of data that shows that the cost of healthcare goes down, the quality of healthcare goes up, and the mortality rate goes down in direct relationship to the number of primary care physicians that are in the health system. And so it's really important that we provide that solid basis, that foundation of healthcare in terms of family physicians. Especially in our rural areas, it's important to have access. There are a lot of conditions that people are either unable or unwilling to travel for several hours to get their health care. It's important that they have somebody locally who can meet their needs.
The family physician is so important because that person really can get to know the patient and the family unit and the community and the population that they live in, get to know what are some barriers to them getting health care, and get them connected to resources in the community, whether that be counseling services, social support, helping them to have lifestyle changes which would prevent some of these chronic illnesses from happening in the first place.
Delivering care at home is kind of the idea, whether it's in a home city or in the nursing home or just a few blocks down the road. Being able to bring specialty care or effective care to a patient where they're at is very important. Well, it's 2018. Different parts of the country are getting closer and closer together, but a lot of individuals, older populations in small town, really don't like coming to big cities. So having a provider who can communicate all aspects of their care without the need of a specialist really can help coordinate everything and make that patient feel at ease.
I think one of the other things that physicians don't always understand is there's some patients that won't go to a specialist because, the old farmer, I'm tough, I'm going to tough it out. They're kind of resistant to go to people they don't know. So the rural practice doc that they know well, they'll see in the clinic and everything, or out in the community, they're more likely to go see, trust more, and that really helps get their health care started rather than them avoiding, hospitals and the medical field in general.
I love the diversity of the types of patients that you get to take care of. So whether that be socioeconomic, age, gender, diversity of ethnicity and things like that. And I wanted to do a little bit of everything. And so family medicine is a great specialty for people who kind of want to cater their practice to what they want. So if they want to do some obstetrical care, if they want to take care of women's health, if they want to do chronic disease management, pediatrics, procedures, the list goes on. You can really cater it to what you want. So that's one big reason I chose it.
Being able to access kind of a practitioner who was able to comprehensively give care to myself, the rest of my family, my sister who was diagnosed with diabetes, all in one clinic was kind of very convenient and very reassuring.
Going into medicine, I kind of thought I was going to go into family, but wasn't sure. Started clinicals, I kind of liked a little bit of everything. What I found myself getting frustrated with certain specialties was you didn't get to see the whole patient or treat the whole patient. I didn't want to be just known as the heart guy. I wanted to be able to treat everything. And with family medicine, you also get to do everything. It's kind of the last frontier where you can, you'll see everything from heart to GI problems. You'll see OB patients. You can work in an ER. You can do inpatient. So those were all things that interested me during my clinical years. And with family medicine, you can do that, particularly if you go rural, which is where I want to go.
For me, I'm very interested in keeping in taking care of a patient population that's diverse in terms of ethnicity, socioeconomic, and age, and things like that. So I would like to take care of pediatrics patients. I would like to help with chronic pain, and I do a lot of osteopathic manipulative treatment, and that's one of the things that I'm pretty passionate about. So using that as a way to treat pain in patients, and doing some deliveries on the OB floors, taking care of some women's health issues, and then possibly even doing some palliative care.
Community is a big drive of what I do, and being part of a small town community, a positive member, is very important to me, and I plan to head to small town southwest Minnesota for the rest of my career as a significant member there.
One of the things rural medicine kind of gets a stigma, or family practice in general gets a stigma of they're not as good as the specialists, but I think when people go out in rural medicine and actually see how rural physicians train and how well they are in a broad scope of everything, I think that's kind of an underemphasized, underappreciated portion of the medicine.